I'm going to do my best at saying like, hey, this is all the helpful information. This is where questions come from. This is the approach. These are your BAM moments. If you've never come to my session, hopefully you'll see this, but this is kind of how I teach. Have you ever watched any of my stuff before?
No, I've never actually watched, but people have told me that they're good, so I wanted to come to the session.
Okay, good. So pretty much these ones are live and new. They're different than my YouTube channel. I am not going to do microbiology like systems. I will at some point. Maybe that's what I should do next week is general microbiology. I actually have a lecture I'm working on putting together, and maybe that you gave me that idea. I'll do that next week because I am a microbiologist. That was what I did before medical school, and that's why I have that on my YouTube channel. So they are really good, and when you get to those systems things, like they're going to be super helpful for you. But otherwise, this is just for helpful reiterating things that show up on your exams, as well as where it comes into play for steps as well. So tonight we're going to go over some of the basic cells that show up and how they're important for you as a doctor, because who needs to know every tiny little receptor on every one of these things? Not me. So one of the most important things to start off with is understanding kind of where the cells come from and why we call it right or left shift. Have you ever heard the phrase right or left shift before?
Only towards a graph.
Yeah, right. So it is originally placed from graph, but left is really in the aspect towards the myeloid line and really specifically towards the precursor cells. So whenever it says left shift, it's like we're seeing an increase in band cells or precursor cells before we get to the mature cell line, which is pretty much these guys over here. And that's what we're really talking about. But for your purpose in understanding this is to know that in the bone marrow is where all of these cells develop. And once we are in the bone marrow, we have a lineage of either to the lymphoid cells or to the myeloid cells. Now, for your purpose in immunology, I'm going to focus it on you, term 3 student, is that you should know really the growth factors or the interleukins that will stimulate these guys. The most important is going to be this guy, GM-CSF, or granulocyte or granulytic myeloid cell stimulating factor or colony stimulating factor. And this is a hormone that will stimulate a left shift or production or increase of pretty much the end result in most number neutrophils, but we'll make some of these other ones as well. And this is actually medication we can give on cancer patients. And this is a helpful medication that we use to regrow their bone marrow or like stimulate their bone marrow back to grow after we give them chemotherapy. And that's where this hormone kind of comes into play. And that's how to remember that what is the most depleted cell line in chemo patients is the myeloid side. And especially most important is the loss of neutrophils. And we will measure these with an absolute neutrophil count or an ANC. This is a number where we count exactly how many neutrophils we have in the blood or an estimate of that so that we can tell, is this person very innately immunodeficient? And there's 2 types of immune systems. There's the innate and there's the adaptive immune system. The innate is pretty much like your first line of defense. You have your borders like skin and stuff like that. And then once they break, then you have pretty much macrophages, monocytes, neutrophils, all of these guys pretty much right here are your first line of defense. And they're called the innate immune system, okay? And the most important in regards to the innate system is your neutrophil. The second is your macrophage, which is right here. Now, in the myeloid side, we have different stimulating factors that will grow a more specific cell type than another cell type. And that is some things that you should absolutely know, especially for erythropoietin, for example, causing erythroid precursors. And where does this come from?
In the blood.
It's in the blood, but what makes it?
Bone marrow.
No, kidneys, right? So kidneys make erythropoietin. And so when you have kidney cancer, you can have too much erythropoietin. You can have increased hemoglobin, say like, for example, like greater than 18 or something like that. You can also have chronic kidney disease, on the other hand, where you actually have low erythropoietin. And that's why chronic kidney disease leads to a normocytic anemia, just because I'm deficient in the hormone that's supposed to be stimulating the production of red blood cells. And that is where that hormone comes from, your kidneys. Thrombopoietin, you don't need to know where it comes from. Just know that it's similar to the erythropoietin, but it would promote the production of platelets. For basophils, what are basophils for?
Allergic reactions.
They are for allergic reactions, and they are important for killing bacteria and different things that are opsonized as well. And when they're located in tissue, they are called mast cells, but when they're in the blood, they're called basophils. And these are the ones that are really the most rare to find. You can find platelets easier than you can find basophils in the blood. Now, what do they look like? It pretty much looks like a dark ball of nothing, and that's it, just a bunch of granules. You don't really see anything else in the cell, and that's how you spot a basophil. Now, if you had a large like blood smear, and you saw these little red blood cells, and you see a bunch of basophils, right? You see multiple of them. Really, on a peripheral smear, if you see really 2 or more, because they're so rare, you shouldn't really ever see 2 on one slide, right? If you see a whole bunch of these, you should be very concerned for a disease called CML. Do you know what that is?
No.
This is called chronic myelogenous leukemia. Now, you will get this in term 4. You'll learn all about it. And I'm just giving you a hint that remember the basophil. It's really the only disease that a basophil is important to you for. I just don't want you to forget it, okay? It's going to be very important for this disease, chronic myelogenous leukemia. And so just remember your basophil for that disease. It's going to help you pick it out and get free points later on. But for your purpose right now, it is the same as a mast cell, just in the blood, and they will secrete out histamine, bradykinin, and bradykinin causes like more of the itchy irritation or pain, depending on how much is secreted. And then histamine is going to cause some itching as well as vasodilation. It's going to cause increased permeability of your blood vessels, and that will allow for more seepage of stuff. So that's where you get like wheals and hives and stuff with an allergic reaction. And it also is the mast cell that causes the redness around swelling whenever you have a skin infection or irritation to somewhere, okay? And so that's just something to keep in mind for those cells. What does an eosinophil do?
It fights parasites.
Fights parasites and?
Don't remember.
So it fights parasites. I'm going to clean this up a little bit here. So it fights parasites. It also fights fungus. When you have disseminated fungal infections, fungal pneumonias like coccidioidomycosis or histoplasmosis, all the things you'll learn in microbiology from my videos, most likely, are going to be things that increase your eosinophil count. Another thing that increases eosinophils are like drug reactions. So we will do this in just a little bit. I think I have an eosinophilia slide, and I'll go over some of those things that cause eosinophils to go higher than they normally would. They are pink on a slide, and how you can spot them is there's our pink guys right here. So those are eosinophils. So you can see that they are very pink in the cytosol, versus neutrophils are purple. Lymphocytes are kind of blue-purple. There's some lymphocytes as well. Actually, this is a monocyte, and basophils are just dark little blobs. And then this is a downy cell, which is a cytotoxic T cell. That is responding to someone with Epstein-Barr virus or mono that you will see. So you will see all of these cells. You should know what they look like and be able to spot them very quickly and very rapidly and never forget what they look like, okay? So eosinophil is very pink. And if you see a whole bunch of them, and if you have questions that point to them and say, what would increase these? And you have answer choices, you should be thinking parasites, fungus, drug reactions. And what do I mean by drug reactions? I mean like giving someone penicillins and they have an allergic reaction to them, or giving someone aspirin and they have allergic reaction and they have inflammation of their kidneys because of the aspirin. All of those are going to increase eosinophils, and you're going to see those in those particular cases. There's a whole bunch of other drugs. You can take a picture of the chart when we get to that slide, but for the most part, drug reactions, it's common to recognize eosinophils go high. Now, what's the fifth letter of the alphabet in English?
E.
Eosinophil, right? So IL-5 is the stimulating factor for eosinophil production. If you ever want to know what that is for, it is for eosinophils, okay? Granulocytes, monocytes. So granulocyte monocytic progenitors go to two factors. One, neutrophils. And do you know the receptor that goes right here? I don't think you do, because I didn't teach it. It is vitamin A receptor. And you might go, what? How does that have anything to do with this? Well, this comes into play when we're treating acute myelogenous leukemia rather than chronic. And you'll learn this later on, that acute means I have a bunch of precursor cells that are overproliferating and causing cancer, versus chronic is a bunch of mature cells. So I will have a bunch of basophils, I have a bunch of neutrophils, I have a bunch of eosinophils that are overproliferating, and that's what the chronic. So you have chronic lymphocytic, you have chronic myelogenous. Both of those mean mature cells. And acute means blasts, or like precursor cells that are cancer. So in acute myelogenous leukemia, there's a particular type, PR3 or pro-myelocytic one. You don't need to remember that at the time, but it will, we actually treat it because it's too much of this cell type right here. And when we give vitamin A or all trans-retinoic acid, we actually stimulate this receptor and cause it to turn into a neutrophil. Now, neutrophils live about 1 to 7 days long, and these precursors live about 130 days long. So imagine if this cell was overproliferating and doubling every day and could live 130 days, we would have a lot of tumor. But if I gave a drug that made all of those overproliferating cells only live for a week, I could almost treat the cancer in a week, right? And all of them would die instead. So that's the purpose of using this vitamin A receptor for the transition towards neutrophils. The monocytes are just general like macrophages in the blood, and when they get into the tissue, they become macrophages. And then there are specific dendritic cells, which are like not as phagocytic macrophages, but they're more of antigen presenting cells, both of these antigen presenting cells. What is an antigen presenting cell?
It presents antigen.
To what?
It presents the antigen on the MHC 1 or 2.
Okay. And what are those for?
They're for like the macro. Well, don't know.
Okay, good. Well, we're going to discover that today. Okay, we're going to work on some of this, and if you're coming to the other sessions, you will learn it. Okay, so don't worry, it's okay. If you haven't done immunology before this point, that's why I'm doing these sessions. I'm helping you catch up on some of the basic things that I had in my undergrad that I just kind of doubled up the experience upon in medical school when I learned it. And since I've been teaching it and tutoring it, I want to bring that to your knowledge base. So I want to help you understand what is going on, what are these cells, what's happening. And so that's what I'm trying to get at here. So it's okay if you don't know, you're not alone. And I just want you to feel comfortable in knowing that, okay? Let me come back to this slide. I'll come back to eosinophils after I do some of these things. So let's talk about MHC, okay? So MHC1 and MHC2 are pretty much two genetic areas that present or create receptors that present things. And we're going to really go into this when it comes down to our session 4. We get into the nitty-gritty details of all of this. But for the most part, MHC class 1 will present to CD8 T cells, and MHC class 2, 2 squared, presents to CD4 cells or CD4 positive cells. The CD4 positive cells are your helper T cells, and there are pretty much 4 types of helper T cells, 3 helpers and 1 regulatory helper T cell. And those types of T cells are where we get this chart here, okay? And it really depends on what type of helper T cell you need for a particular type of help. And in cases of parasites or fungus is where you're going to have an increase in Th17. Is that important? Not really, okay? You still will have T helper 1 cells. They're both will be there. You will just happen to see an increase in T helper Th17 cells. And it's not, again, really that important for you to know much about what the T helper 17 has to do with, other than it has to do with like allergies. It has to do with fungus and fungal infections, as well as some parasitic infections, okay? On the other hand, this one that is very important to know is your Th1. Now, your Th1 is your classic, most important helper T cell. It's the one that's going to interact the most with your B cells to make IgG antibodies. It's going to be the most important one in regards to responding to tuberculosis and bacterial infections and viral infections, like in regards to creating walls and granulomas and walling off the infections so it doesn't get out of hand. We'll talk about granulomas in a minute. But it's very important to understand that Th1 is really the most important guy here. Now, there are pretty much 4 things that you really need to know about the interleukins and interferons and the cytokines related with Th1. And so you should know this, okay? IL-12 is a hormone that gets secreted from macrophages, and macrophages spit this out, and it's pretty much their verbal communication to the T cell and say, okay, I need your help. Just generally, if you were to pick Th1, Th2, Treg, and Th17, and a macrophage said, I need your help, which one are you going to be? You're going to be a T helper 1, okay? And so that's why it is the one that stimulates your Th1 receptor, okay? And when you stimulate that with this verbal communication of IL-12, you become a Th1 receptor. Now, you have a receptor for this. It's called an IL-12 receptor. If you have an IL-12 receptor deficiency, you have a T helper cell deficiency, and that will lead to a T cell immunodeficiency. What will that cause? It will be similar to HIV. It will be similar to a lot of the T cell things like the George. I mean, obviously, George has other factors involved with it, but it will cause someone to have oral candidiasis. So thrush, for example. It will cause someone to have TB infections, right? And this is the special one that I want to emphasize for IL-12 deficiency, IL-12 receptor deficiency. And yes, it is in first aid. If you happen to have a first aid, it is in your immunodeficiency T cell chart. And what's very important is that if you have this receptor deficient, you have a deficiency in your T cells. Now, once you activate your T helpers T cell, it communicates several things. It will secrete out tumor necrosis factor alpha, which is a pro-inflammatory cytokine, which causes fever, it causes weight loss, it pretty much causes the feelings you get when you get sick from viruses like flu. Those symptoms you have, that's tumor necrosis factor. The weight loss you experience over those few days when you don't want to eat, the feelings of not wanting to eat, all tumor necrosis factor alpha. IL-2 also does similar, but this one's also very special in regards to telling your T cell to proliferate. So make more of yourself, duplicate yourself, so we have more of your specific type of helper. Interferon gamma is the repeat conversation with that initial macrophage. So say the macrophage is here, macrophage, okay? And it communicates back up to the macrophage and says, hey, keep sending me IL-12. So it creates this cycle of communication with it. Now, if you didn't have IL-12 and IL-12 was fine, say IL-12 was there and IL-12 receptor was fine, could you have this same disease but with something else? Yes. Deficient interferon gamma or interferon gamma receptor deficiency. That could lead to exact same disease. It's just from the circle communication that is deficient in this patient or in this person, okay? And that is the most important out of this page. Do you have any questions?
No, I don't think so.
Okay, good. All right. On the other hand, over here, your Th2 receptors, remember bacterial, tuberculosis, and viral things really are controlled from this helper cell. Yes, I will talk more about other types of T cells like the CD8 positive cell and how they respond to viruses. But virus over here, bacteria, and TB. Now, on the other hand, we can have these cells over here. IL-4 is for your Th2 type helper cell. I don't like, most of these are not super important. You could study them a few times so you know that they're being secreted, but I would just remember the IL-4 in regards to the Th2. Now, Th2 responds more to your sides of parasites and fungus. And that is where we are going to be communicating to our other cells. I totally spelled parasites, whatever, parasites, you get the memo. I never spell right while I'm talking. So Th2 on the other hand are the cells that will communicate the appropriate coordinated response against those parasites and fungal infections. Now, one weird thing about this imbalance over here, yes, these guys will be anti-inflammatory cytokines, but they do respond to these guys. So don't forget that they fit under this umbrella here. They also fit under Th17, but both of those responses go towards these guys, and they'll never have you differentiate that. That's ridiculous. For the most part, Th2, the one thing that I want you to remember is in a particular disease case called leprosy. You ever heard of that before?
I have.
Okay. So in leprosy, there are two types. And there is Lapromidus leprosy. And Lapromidus leprosy is one of the ones where we have a response that is very deficient. It is inefficient type of response. And that is where I have the patients where they're losing limbs. We have bumps and rashes, as well as numbness. It's pretty much the ones you always hear. And that's called Lapromidus leprosy. The other is tuberculoid leprosy. So could you guess which response is appropriately happening for our leprosy patient? So is the Th2 causing Lapromidus, or is it causing tuberculoid leprosy?
The Lapromidus?
Yeah, exactly. So the Th2 isn't really great at fighting leprosy, so it creates what is Lepromanous. Leprosy. Lepromanous leprosy is widespread bumps, rash, toes falling off, all this stuff, organs dysfunction, numbness, all that stuff. Loss of nerve function, and that's why people injure themselves, just like diabetes would injure themselves and cause ulcers on the bottom of their feet. This is what's happening to these patients. If the Th1 is the primary response against the leprosy, because leprosy is a bacteria, just like tuberculosis is, if it's a Th1, it's going to have better control of it. Just like you would have better control of the tuberculosis with the Th1, you're going to have better control of the leprosy. And this is called tuberculoid, sorry. Tuberculoid. And tuberculoid leprosy is very mild, less severe. They just have some numbness and maybe some discolored skin, but that's it. And this is far better and less disfiguring for our patients. And this is really the only question out of the probably 30,000 questions that I've done from every possible question bank out there. I've only seen this one repetitively over and over and over about the difference between tuberculoid and Lapromidus leprosy, and in regards to coming down to the immuno between Th1 and Th2. Really, you do not get many questions beyond that point about these guys. So keep that in mind when you're going to study and you're going, do I need to know every single tiny thing? IL-4, IL-10, all blah, 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 all this stuff. No, you just need to know when we're talking about Th2, it's like parasites and fungus, as well as like a little bit of anti-inflammatory. And then the Th1 is that pro-inflammatory, fighting the bacteria, fighting the TB, fighting the viruses. It's the main response is from your Th1. So it's almost like you're, when in doubt, pick a Th1, interferon gamma, IL-2 or IL-12. If you go with that, you're probably not going to get anything wrong unless they say, why is the person losing weight or having fever? Pick tumor necrosis factor. Okay, that's a money point right there. Right? Any questions from these guys?
No.
Okay, so back to MHC class 1. So MHC class 1 goes to CD8, and MHC goes to CD4 positive, right? And those are your helpers that we're talking about. CD8 are cytotoxic T cells. They're the ones that go over to the virally infected cells and directly kill those cells to get rid of the viruses. Also goes over to cancer cells and kills them as well. They act almost identical in a little different way, but like the same response comes out of them as NK cells. Did you learn about those?
I have learned about them.
Okay, good. So we'll talk about those maybe at the end of today or at the end of session 4 this weekend. But so let's talk about development of the T cells and the T cell receptors, because this is going to be where you're going to get a bunch of questions, especially when we get to B cells. So T cells, they start off in the bone marrow, right? And in the bone marrow, they have nothing on it, pretty much naked. It isn't until they go into the thymus, which is right here, that they upregulate all the receptors. And this is called a double positive. And a double positive cell means we have both CD8 and a CD4 T cell. So if I had a T cell precursor or a pre-T cell cancer, what would be the differentiating factor about them is that I'd be naive of all of those receptors. I'm missing them, absent. That would be a factor. I would not have my markers for it. Do you know what the general B cell marker is? I'll give you a hint. It starts with CD.
It's not, I don't remember, but I remember hearing about it in lecture today.
CD3. It's all right. It's all right. So all of your single digits, like 1, 2, 3, 4, 5, 6, 7, 8, 9, and then 10, those are T cells. Okay, so that's helpful. If you're in the teens and low 20s, you are in the B cell world. And if you're in the 30s, you're in the NK cell, the macrophage, and the other antigen presenting cells, other than B cells. So CD19-20 classic for B cell, and CD3 classic for T cell. So if you ever see like a flow cytometry and they're like CD3 over here, and they draw out the little chart, and this is negative, this is positive, and you have some dots over here, and then this is say CD19, and this is where our markers come in. We have T cells, pretty much. If we were here, this is B cell absent of CD3, so this is positive for CD19 and negative for CD3, so that is a B cell. T cell. Okay, very important concept, nobody really explains. So CD3 is your marker, baseline marker for all T cell types. I mean, all the ones that we already talked about here, all of those have CD3 in them, okay? And so wouldn't it be weird if you had a B cell that was over proliferating and producing a CD5 molecule? Yes, that is a B cell cancer that over proliferates a T cell receptor. That's where you start getting into pathology when you do your hem-onc section, and you'll see those CD markers come up, and you'll be like, oh, this is a B cell cancer. And I have CD10 positive on there. That's supposed to be for your T cells. Why is this B cell expressing it? Oh, it's because it's cancerous. And there's only 3 cancers that have CD10. So like you just kind of limit it at that point, recognizing this is an abnormal receptor. This is not my normal T cells, okay? So that's something to be very important, is that all of these guys do not have 19 and 20, they have CD3 because we're on our T cells. So once we get into the thymus, we are double positive. And then what do we do? What do I do in this cortex outer thing? And I'll give you a hint. It starts with positive and ends with selection. What is positive selection? Do you know, or do you want me to go over it?
I don't know.
Okay, great. So this is very important, okay? It's easiest to remember negative selection, but you got to remember which one is first. So I have a precursor T cell that's no receptors. I come into the outer part of the thymus. Here's my thymus. I come into the outer part, which is the cortex, before I go deeper into the medulla and then head out through the pipes. Okay, so it's unidirectional when I'm coming into the thymus. So I'm in the cortex. In the cortex, I express both receptors, CD8, which is the red one, and CD4, which is the orange one in this chart, respectively. I am double positive. And so what I must do is I'm going to see how my T cell receptor works. And what we want to do is we want to determine, okay, when my T cell receptor comes over to an antigen presenting cell in the thymus, so here's a big antigen presenting cell, I'm going to put a little smiley up here, okay? When my T cell comes up here and, you know, hugs this antigen presenting cell with this little cheek tattoo, he is going to recognize what he responds to best. And what does that mean? It means MHC1 or MHC2. If this T cell receptor likes MHC1 the most, which cell is it going to become?
A cytotoxic T cell?
Yeah, exactly. Absolutely. And so what does it do? It says, I positively love MHC class 1. That's how you remember positive selection. If I absolutely positively love MHC class 2, I'm going to become a CD4 T cell. That is positive selection that occurs first on the outer part of the thymus, which is your cortex, before it heads deeper into the medulla. Now, the medulla is where negative selection. Now, if you remember, if you're writing anything like plus or minus, that's how you remember your order. It's always positive first and then negative second. So it's like just your general conversation, like plus or minus this, you know, you always say it that way. That's the order that this is: positive first, negative second. Negative selection is very important because now I have a cytotoxic T cell. and I have a helper T cell. We want to remove out these cells for what reason? Why would I want to make sure I don't let this cell go down the pipe and escape out to the body?
Is it because CD4 cells are the helper cells, so they would cause the neutrophils and everything to come?
Well, that's definitely something, but what's most important is both of these guys here, right? The initial step in positive selection was just to see, can we stick to an MHC class 1 or MHC class 2? But what does MHC actually do? It presents antigen, correct?
Yeah.
And we want to make sure that these cells only respond to antigen that is not supposed to be in our body. Correct?
Right.
And so if we just release them at this point and didn't do negative selection, some of these cells would go out to the kidney and say, hey, I don't like this, and kill it. And that's how I get autoimmune diseases, is I do not negatively select very well. There's other ways that you can do it too, but for the most part, negative selection is my way of trying to prevent autoimmunity. Instead, I want to kill off those or negatively or remove them from my circulation and not let them out. I only want those who are very loving of my MHC molecules, but will not respond to self-antigen. So there's a different APC that occurs here in the medulla. And the medulla has these endothelial lining cells. You don't need to remember the name of this, it's fine. Pretty much these cells, what they have the ability to do is they have the entire body's genetic makeup, and it's really cool. And so I'm going to actually do a blank, or I'm going to draw on this page just so you can see. So on in our big antigen presenting cells in the medulla, what they have the ability to do is upregulate thyroid gland. They are able to upregulate kidney, able to upregulate lung, brain or blood-brain barrier. They're able to do skin, and really from the genetic makeup, make all little pieces of antigen from all of these organs around the body to make sure that when my little, CD8 T cell comes along and he's coming in for negative selection, doesn't respond to my own genetic makeup, like lung, for example, and start killing off the lung once we release it. If it responds in negative selection, so if you have a cell in the medulla of your thymus reacting, you got to kill it. It's got to die. It cannot go out, because if I release it, it's going to go kill that organ, whatever it responded to. So if you have a proliferation occurring in the medulla of your thymus, specifically in the medulla where negative selection occurs, that cell's got to die. Very important. If it has no reaction to any of all the thousands of antigen that those cells put out on their surface, it just goes along all the receptors and tries to see if it responds to any of them. If it responds to none, it now is a strong binding of MHC, but a poor self-antigen reactor. So therefore, it's ready to react to something that doesn't belong in the body naturally. It goes out, and now it is a helper or a cytotoxic T cell. Does that make sense?
Yes.
Great. Hopefully this is more helpful than your lecture. And then, as we were talking about all the other things that occur with the helper T cell, we don't need to do that again. In B cells, they're quite a bit different. Now this, I'm going to go down a little bit of immunodeficiency, but I'm not going to give you all the spoilers for this guy, because I want you to come back to my other session when I go over immunodeficiency. So again, B cells occur in the bone marrow. So where do T cells become mature? Thymus, right? B cells, they grow and become mature in bone marrow, and then they go out to the periphery. They hang out in lymph nodes, they hang out in spleen, hang out on some in the blood. And they end up producing a bunch of antibodies. They're our main antibody stuff, but they also can do phagocytosis. They also have MHC class 2, so they can present antigens to T cells, just like a phagocyte would. It's not their main function, but they can do it. Just know that B cells have that ability. So in the bone marrow, we have this pro B cell, and then we become a pre. And so I just remember PR0 B cell is the first one, and then PRE as the second, before we become immature and then mature. So that's how you remember the order. I always, for a long time, would mess up pro and pre, which one's what. Pro is PR0, so it's the initial one, okay? So in a pro B cell, again, just like the T cell had nothing on it, we also have nothing on it. What makes it a pre B cell is we start producing our B cell receptor and the co-receptors that are there, which you do not need to really know. But just know that you start creating your B cell receptor. You also have a very important gene called BTK. Do you know what that is?
No.
This is called Brutons Tyrosine Kinase. You ever heard of that before?
Never.
Have you had your immunodeficiency lecture?
No.
Okay, well, when you have your immunodeficiency lecture, this is right where it is. All right. So this gene is required to pretty much upregulate your pre-B cell receptor and allow you to go to the immature state and then head out towards your lymph nodes. If you are deficient in this, it's an X-linked disorder. It's called Bruton's A gamma globulinemia. Pretty much means no B cells, no immunoglobulins, immunodeficiency. It's X-linked, occurs in boys more commonly, and starts affecting them starting at 6 months of age, once mom's antibodies in the bloodstream decrease. And this is right where it is. If this is deficient, I can't get the cells out of the bone marrow. I can't get them into the lymph nodes. And so are the lymph nodes really going to be there? Yes. Are they going to be full up like balloons with B cells? No. And can I do a physical exam and see something that is very special about Bruton's patients? Yes. They do not have tonsils. They have very scant, minimal ones. That is one special things about Bruton's A gamma globulinemia, is that they don't have B cells filling up their tonsils. And tonsils are lymph nodes, external lymph nodes in the mouth that we can see. So if you ever have a question, it's like this kid's having multiple infections and they have no lymph, like scant lymph nodes or no tonsils, there's your answer. Easy, free point at that point. If you're given that and you get it wrong, don't do that. Okay, so that's where that comes from. Once all of these set in stone and we start making a mature B cell receptor, we become a ready to fight immature B cell, but since we're in the bone marrow, it's still considered immature. Once we come out, we're considered mature, okay? Now, immature B cells, it's very important what we do from there, okay? We have a IgD receptor, we have an IgM receptor, we have our, which is our BCR or B cell receptor, and then we make immunoglobulins, right? So when we make immunoglobulins, we can mature into an extra mature B cell that pretty much only purpose is to make immunoglobulins, and that's called a plasma cell. The only thing that's really different that you can see is they have extra cytoplasm. That's it. And this is the cancer type that overproliferates in what is called multiple myeloma. And they make a bunch of immunoglobulins and have a whole bunch of stuff that you'll learn forever and ever and ever, and have thousands of questions, so you'll never miss it on step, so don't worry about it. But for the most part, we have our receptors and then we make our immunoglobulins. Now, there's different types of immunoglobulins. What's the main one that if a B cell is able to make one type of antibody because they're lazy, what's the one they're going to make?
IgG?
No. It's going to be IgM. So IgM is the basic basic immunoglobulin. Is the first immunoglobulin that you will make, that you can secrete out. It is the first one that responds to initial infections. So say you get flu, first time, never had flu before, you get flu, the immunoglobulin you make is IgM. If you get flu again, then you make specialized flu antibodies, which IgM can never be specialized, it's generic. And those will be IgG for viruses, IgE for parasites and fungus, IgA for mucosal infections, so upper respiratory tract infections, GI bugs and diarrheal diseases, and allergen stuff sometimes, IgE as well with allergens. And then IgD has no function, you don't need to know about it, okay? It's there, but it's dumb. And that's why we call it IG dump. And then our last one, wait, IgA, IgE, IgD, IgM, IgG. Okay, yeah, those are your immunoglobulins. Now, IgM is very special, in that it is huge. It is a pentamer. There's 5 antibodies stuck all together, but it is the initial one that we will make. And in order to switch from IgM over to, say, IgE, because we have a parasitic infection or a fungal infection or allergies, or switch over to IgG because we have E. coli, pyelonephritis, bladder infection, and kidney infection, then we need cytokines and we need T helper T cells. Okay, so helper T cells are the guys that come over and help coordinate class switching. And they will have certain other cells like macrophages and neutrophils out in the field saying, hey, we need IgG. And how they say that is by a certain cytokine. They say, we need IgG because we have bacteria. IgG gets, or the cytokine gets secreted out, heads back to the bone marrow, circulates in the blood in high enough levels that the T cell says, okay, B cell, I'm hearing from our troops out in the field that we need IgG. Here's the cytokine that you need to switch from IgM to IgG. Or if it's a parasitic infection, same thing goes down, but he says, okay, here's the other cytokine in order to make IgE, so which is like IL-4, for example, right? So those class switching things occur between a helper T cell and a B cell's communication at this stage here, right? And that is called, when we switch, isotype switching. That's what it's called. And we'll address this again when we go over our immunoglobulins in one of our later sessions. But that's the general gist. And then if we have recurrent infections that occur over more and more, we end up like sending some B cells that were responding to hang out in the bone marrow or out in the periphery like lymph nodes, and they're just chilling and proliferating each other over and over just to make sure I keep making that same flu antibody. And that is where we get in memory. And that's really the basis of a lot of our like live attenuated vaccines, for example, are really great at ramping up our memory cells. Okay, so that is where this comes into play. Do you have any questions from here?
No, I don't.
Awesome. I'm glad that is clear. Okay. This in first aid more applies towards the step 1 students. I'm not going to go over this for you because it's crazy and you will learn this when you get to path, and there's not super high yield stuff. But just for your learning purpose, whenever you learn about HLA-B27 and ankylosing spondylitis and reactive arthritis, and you'll hear this like 10,000 times, and you'll know exactly that Clark taught you during this lecture about this, is recognizing when they start talking about them, when there's one single letter, it is MHC class 1. And when there's 2 letters like DQ, DR, right? These are MHC class 2. Just so you know. So if they start saying like some weird genetic based questions, you know, the ones where they're like, an experimenter does this random thing that's never going to help anybody, but we're going to test you on it anyways, just so you get this concept. And they start talking about DR3 and B27 and stuff, and it's like, which one is going to be appropriate as a similar response to like viral infections. And you're like, virus, CD8, that responds to MHC class 1. I'm going to be looking for my B27 or B8 or something like that, right? It's going to be associated with MHC class 1. So something along that lines, just keep that in mind for these guys. That's what the 1 and 2 letters are for MHC. These are just random specific types of MHC class 1s that are associated with these diseases and stuff, and you'll learn those out later. For those who are studying for step 1 and listening to this at a later time, this is decently high yield, but don't waste too much time on it. Make some flashcards, memorize them, and that's it. Okay. Last few things that we're going to do in the last few minutes are some of the basic cell responses. Neutrophils. Please memorize everything from this chart. And if you have lecture slides with even better ones and better explanations, and you can go on YouTube and watch up like neutrophil phagocyte extravasation with CAMs and cellular adhesion molecules, please watch it, memorize it, know the integrins and the things that help bind and stick and roll and adhese, so you know how a neutrophil will get out into the interstitial cells and respond to infection. You get a cut, and the neutrophils go through the blood, rolls, adheses, transendothelial migration, and now they're in the tissue and they can respond to the bacteria in that cut. That's what's happening here. Integrins, you can have deficiencies in this and lead to something called leukocyte adhesion deficiency, or LAD, or LAD. I always remember this as a little boy with here, and he's sad and crying because he has little snuffle noses and like multiple infections, and he has all these skin infections, and it's radiating and hurting. At the same time, he has his umbilical cord is still attached, and he's like old. And you're like, what? So this is delayed umbilical cord detachment. You ever hear that? Think of this disease, okay? And it is an integrin problem for neutrophils. The neutrophils will be stuck in blood. So if I draw the blood out and do a blood test, your white blood cell count, whoops, is going to be sky high, and it's going to be super high in neutrophils. And you're going to be like, why? And then you look at the skin infection and there's going to be no pus. Neutrophils are great at making pus, and there's no pus. That is this disease right here. What's deficient? Integrin, right?
We had a question on this today.
Yeah, and it is called CD18. Got to know that. Super important. So know all of these things, what help them go to stick and go into each of the steps. Very, very important. They love this stuff. Okay, you have that question, you're going to get it more. It's guaranteed on your test. No doubt. They love this thing. It shows up on step all the time, so they're going to put it on your exam. So very important. Okay. And this is something that is similar, except for I'm not going to talk about all the things that it takes to get in here. What I'm going to throw out is what is causing stuff to happen. So histamines and prostaglandins, leukotrienes, mainly histamines, are going to cause endothelial-like contraction and opening up, and that increases permeability. It also will go to the blood vessel and cause dilation. Okay, mast cells are things that secrete that. And then when a neutrophil gets into here, how does it know it needs to go over to this area rather than to his friend's house down here? Here's his little friend. Why wouldn't he go over down there instead of go over here to fight bacteria? Is because there's gradients of chemotactic factors. And the things that you need to know are C5a and leukotrienes. And can you tell me the specific leukotriene?
No.
B4, okay? So when the neutrophil comes in and it recognizes this from before, it's going to go over to where he remembers that the infection is. So LTB4 and C5a. Now you're going to classically have C3a as a nice answer choice there. And you're going to go, wrong. It's not what it does, okay? What does C3A do? Fever. C5A. Fever and chemotaxis. How do you remember this? You got more numbers, you got more functions. Fever and chemotaxis. That's how you remember that. Never forget it. Okay. Anything else? Also a chemotactic factor.
I don't.
Huh?
I don't know.
That's all right. So some of the things that cause chemotactic factors are specifically called the chemokines, and under chemokines, you'll have to refer to your interleukin chart for which ones are chemokines, but I think it's CXCR8, and that's the receptor. So I think it is like IL-8 that is the one that is a chemotactic factor. But you can see your interleukin chart for that one, but they love that. The most important, the one they test the most on and everyone forgets about, the leukotriene, is the leukotriene B4. Okay, don't forget about it. Very important. Shows up all the time. Okay. And I was scarred from this because I got this wrong when I did that exam back in immunology, and I was mad. So it was scarred for me and a lot of people. So don't forget about it. Okay. That draws the macrophages and neutrophils and everything over to the bacteria, gobbles it up, and does its thing. Okay. Otherwise, that's pretty much it from this chart that I needed to go over. Macrophages will gobble it up by itself. They're usually in the tissue anyways. Okay. Oh, what do you know? Chemo-attractive molecules. Who said this? Oh, IL-8. What do you know? C5A, leukotriene B4. And then this random one down here that sure you can memorize it, but you're probably not going to get tested on it. So know these three. That's where these are. So I always remember CXCR8, which is chemokine cell receptor for chemokine factor 8. And that's how I always ended up remembering IL-8. But all three of those guys cause chemotaxis. So the word question of this person has a skin infection or some infection, and then the neutrophils, once they extravasate across into the tissue, how do they attract towards the area of inflammation or infection? They're looking for one of these guys. Okay, very important. And I'm going to get you so many points. Nice. All right. Last but not least is going to be what happens when you phagocytize something in a macrophage or in a neutrophil. And this one specifically is mainly neutrophils, but this is the classic pathway where you can have deficiencies in, and this is called your oxidative burst. Okay. And did you learn this?
Today.
Sweet. And I'm going to help you remember all of this. Okay. So number one, most important, this. Got to know 3 points. And you got to know the special test that tests for it. They're going to talk about this nitrosolium blue test. They tell you about that one?
Yeah.
Oh, what do you know? Guess what step one asks? Not the nitrosolium blue test. You're going to have to learn about the fluorescent flow cytometry test. That is in first aid, the very bottom of that chart. You'll see it right there. It says nitrosolium blue test, obsolete. And then they actually do the other test for chronic granulomas. And just refer to my immunodeficiency session when I do that, and I'll re-talk about this guy. But NADPH oxidase, what does this do? It takes oxygen and creates superoxide. Damage. That can kill bacteria alone by itself, okay? Then this is sort of like what you would call free radical, right? So all these with the little dots are free radicals, and this could kill bacteria just alone. And this is what is called oxidative burst. That's the first step, oxidative burst. Okay, and if you're missing this enzyme to create any DPH or superoxide, you can't kill the bacteria. So if you can't phagocytize the bacteria and kill it, what do you do then? Well, you got to wall it off. You know what we do to wall off stuff? We create macrophage walls. And you know what a macrophage wall is called? Granuloma. Granuloma is where we get chronic granulomatous disease. So these patients will have chronic skin abscesses, a small child with recurrent skin abscesses, and they may have had a brother that died of infections or something like that. Bam. It should stand out to you. And the most common and the choice that you should pick as your answer choice until proven otherwise is Staph aureus. Staph aureus. There are other things that can fight against or cause infections in patients such as Pseudomonas, such as aspergillosis, nocardia. You'll learn all about these guys as they come, but they all produce an enzyme called what? They create catalase, right? And a catalase is an enzyme that helps break down hydrogen peroxide into water and oxygen. You can see that right here, catalase. Okay. And what's important is when I can't create oxidative bursts, we have to start here to kill the bacteria. And our cells can make hydrogen peroxide. They don't have to go through this pathway. They can make hydrogen peroxide from another pathway. And when they make hydrogen peroxide from another pathway, have you ever put hydrogen peroxide on a cut or anything? What does it do? Bubbles, right?
Yeah.
Because the bacteria on your skin is staph, and staph has catalase, it makes bubbles. And the bubbles is oxygen inside of water, bubbles, right? And so these guys are resistant to this part of the pathway. So catalase, positive organisms love this area. They're fine and totally survive this area, but they hate this area. They die up here. But if you're deficient in the enzyme, then great, I will survive, right? And so that is something very important when you're keeping in mind that chronic granulomatous disease. For patients with hydrogen peroxide, if we don't have catalase positive, we can combine it with chloride and make bleach, or HClO. That's what bleach is, and that can bleach these guys. And this is called Myeloperoxidase. Very important enzyme that creates pus. That is what this is here, okay? Pus is myeloperoxidase, chopping up a bunch of bacteria, as well as all the neutrophils in there are dying. And that is very important. Now, if, for example, I have too much of superoxide, which is right here, okay, and if we have too much superoxide, just a side note and reconnection from microimmuno over into the world of neurology, you're like, well, where are we? You did term 2. Did you do neuro in term 2?
Yeah.
Okay. Did you learn about Lou Gehrig's disease or ALS?
Yes.
Okay. And how it has a superoxide dismutase?
Yeah.
There you are. That's your enzyme right there. So what are you left with? A bunch of free radicals, damages stuff. Just a clinical tie-in there. But hydrogen peroxide can go through in our cells to get replenished, and so we're not toxic. You know, obviously, if you drink a bunch of hydrogen peroxide, that's not good for you. And so your cells don't like it very much, and so they can replenish it, use the glutathione pathway, NAD plus and NADPH. Where does that come from? HMP shunt and malic enzyme. Don't forget about that. They will likely test you a biochemistry question here, so don't miss that one. And that is our pathway of our HMP shunt, or pentose phosphate pathway. And that's where we get NADPH. All of this kind of ties in, and our macrophages and neutrophils end up using all of these things. Any questions from this?
No.
Okay, sweet. So that is all for tonight.